All right, now that we have a sense of exactly what Drain and Coulihan have in mind when they talk about treatment being futile, and a better understanding of kind of the theoretical basis of their analysis, let's take a look at some of the cases that they identify as futile and that they think their definition of futility implies are really cases of medical futility. And so one is going to be any kind of treatment that doesn't alter a person's persistent vegetative state. So that's going to include any kind of respirator or ventilator support or nutrition and hydration, which is usually the most common kind of treatment that's provided for people in persistent vegetative states, because as we talked about, they can often breathe on their own. So that's going to be one kind of medical futility. But they also think that treatments that don't alter diseases or defects that will allow a baby to survive beyond infancy, they think those are medically futile treatments. So that's going to apply to certain kinds of maybe genetic disorders or other diseases where the survival rates are incredibly low, where you're talking about babies that only survive for just a few months or something like that. It's also going to apply to anencephalic children. They typically don't live long at all, and it's pretty much sort of a short life of misery. That's another instance where Drain and Coulihan say, like, the treatment there is just going to be futile because it doesn't sort of bring about any kind of medical benefit or goal that the patient or the parents in that case might have. This one is more controversial. The idea that a treatment would be futile if it leaves permanently unrestored a patient's neurocardiorespiratory capacity, their capacity for relationships, or their capacity for moral agency. That one is going to be a little odd, especially that last one about leaving permanently unrestored a patient's capacity for moral agency, because there are some individuals who don't count as moral agents, but where we don't think like sort of any kind of treatment for them would be futile just because it doesn't reestablish their agency. So here we're getting into sort of more controversial cases, where Drain and Coulihan aren't just talking about cases where death is sort of inevitable and imminent, and not cases of sort of unconscious but technically alive. Now we're talking about cases where certain kinds of valuable capacities wouldn't be restored, and they want to say, look, those are also going to be cases where treatment would be futile. And finally, this one is again less controversial. A treatment is futile when it won't help free a patient from permanent dependence on total intensive care support. And what they mean by total intensive care support is going to sort of determine what we think about those kinds of cases. Here's what's really odd about this, though. Because what Drain and Coulihan are really arguing about, and what they're going to insist on throughout the article, is that physicians are somewhat uniquely qualified to make decisions about when treatment is futile. They're going to agree with Donald Murphy in that regard. And the key to the debate in their view is deciding what counts as legitimate medical help. When a treatment doesn't count as legitimate medical help, it can be denied, and then the problem is just how to determine when that's the case. And we saw an argument from Miles that, at least in cases like Helga Wangley, similar to what Drain and Coulihan are saying, that's a case where there was a kind of medical consensus. So there seems to be this continuing thread sort of pushing back against the autonomy paradigm we see in medicine, that no, when decisions about when care will be sort of medically worthwhile, that's really still something that a physician should be able to decide. And what's odd about this is when we look at the cases that Drain and Coulihan regard as futile, there are clearly all sorts of value judgments that are going on. And Drain and Coulihan just sort of accept that. They think that's an inevitable feature of medicine, so there's just nothing wrong with appealing to a physician's medical expertise when it comes to decisions about futility. But you might worry that, again, these kinds of decisions, really are better left to families and not to individuals, or not to individual physicians. And you might also worry that these choices are outside the scope of medicine, that, the decision about whether Helga Wangley's life was a life worth continuing to sustain wasn't a medical choice, right? It was, physicians can make a decision about whether or not a ventilator will keep her alive, but not about whether that life would be worthwhile. So that's kind of that's an odd feature of their view, is this sort of emphasis on a physician's unique qualifications to assess cases of futility, despite the fact that the kinds of cases they count as futile clearly involve these really robust moral and evaluative choices that you might think are really better left to the family than to the physicians themselves. Okay, with that said, let's take a look at what is actually a really surprising argument from Drain and Coulihan. I'm going to give it to you in sections, and what's going to turn out to happen here is that there are sort of three premises that, when combined, comprise their overall view. And so what we're going to get is the argument for each of those three claims that are going to amount to their position. And what they're ultimately going to argue is that physicians are not only not obligated to provide fetal treatment, but also that they're obligated to not even offer it and to refuse any kind of request for it. That's a more extreme view than we've seen so far, and that some people might hold. I mean, you might think that physicians are not obligated to provide fetal care, but that they can if they wish to, and the patient wants it and can pay for it and things like that. Drain and Coulihan want to say, no, even if they want to, they can't, and this shouldn't even be part of the conversation, basically. So here's how that argument is going to work. The first argument says physicians are obligated to promote a patient's best interests. We already saw that's just this principle of beneficence that's well established in medicine. Well, if that's true, they claim fetal care doesn't promote a patient's best interests. There's a value judgment, right? That something like prolonging a patient's life in a vegetative state is not in that patient's best interest. That's sort of an objective thing. That's not something that's a medical fact. That's not something that is open to sort of debate or interpretation from the family or something like that. Well, if those two things are true, then physicians are not obligated to provide fetal care. And we've already seen an argument for this claim, right? We saw the argument from Miles that we shouldn't interpret physician obligations as an obligation to provide whatever treatment they want. And this is a different kind of argument for that view. This is just an argument not about how we should interpret patient autonomy, but basically how we should understand the idea of promoting a patient's best interests. Okay, so that's the first part of their view, that physicians aren't obligated to provide this kind of care. However, physicians are also obligated to respect patient autonomy. That's true. We think that's an important part of medicine. And one part of respect for autonomy is a lack of deception. Most likely that's true for reasons that have to do with what autonomy involves. It requires certain kinds of understanding of relevant facts and having certain kind of information. So when you're being deceived, your autonomy is not being respected because certain information that you need to exercise that autonomy is being withheld from you. Well, here's the most controversial part of this argument. Offering fetal treatment as medically acceptable options is a kind of deception. And what they think is that when physicians offer medically fetal treatment as though what they're doing is suggesting that it's a real, legitimate medical choice, that it's a sort of rational option that patients ought to take seriously. And Drain and Coulihan say that's just false. It's not the case that fetal treatments are rational, that they're medically appropriate. They aren't. So it is a kind of deception to present them as though they are. Well, if deception undermines patient autonomy and physicians are obligated to respect autonomy, that means that physicians are also obligated to not offer fetal treatment. That might surprise you. That's not a claim that we've seen before. It's not a claim that many people make, and it's also a really interesting interpretation of autonomy, that autonomy might involve not offering certain kinds of things. Okay, and then here's the last part of their view. Physicians are obligated to practice medicine responsibly. Trivially, that's got to be true, right? No one's going to say, no, they should practice irresponsible medicine too. The real debate is what counts as responsible or irresponsible medicine. Well, Drain and Coulihan say fetal treatment is not responsible medicine. In fact, it's just bad medicine because it's worthless. It's not of any value to the patient, and that really what patients or physicians should be concerned with is promoting a patient's interests. Fetal care doesn't do that, so it's bad medicine. It's not responsible. Well, therefore, physicians are obligated to not provide fetal treatment. Not only are they not obligated to provide fetal treatment, but they are obligated to not offer it and refuse to provide it. That's a really extreme view, but these arguments are sort of interesting and fairly plausible, and they're grounded in values that are well established in medicine and sort of socially endorsed as things that physicians ought to be concerned with. So think a little bit more about those issues. Think about where fetal care fits in with medicine and sort of how it should be incorporated or perhaps extracted from it, depending on how you feel about the relationship between fetal care and medicine. And then go ahead and take care of the question, which is about that second argument having to do with patient autonomy. From there, we will conclude by looking at the piece by Veach and Spicer, who are going to argue for an opposite sort of view, that in fact, in certain cases, fetal care is actually obligatory, even when physicians personally are opposed to it.